This talk, I think it's very well placed when we're talking about Christina, but also talking or thinking about all the people that are listening right now, because many of you have been impacted throughout your life by dysautonomia, mental health being one of the ways. And so the talk will be about that. And I don't have any financial disclosures or any conflicts of interest. But what I do want to talk about today are several things. And some of this Dr. Golden thankfully already took care of. But I want to talk about the brain, the body, and dysautonomia, because I don't think we can talk about mental health without establishing the real physical things that go along with it. Now, a lot of my talk is going to be about the mental health relationship, because that is an important part of what we're seeing and, of course, what I'm going to talk about. And with the difficulties that come, I hope to give either some tips or some thoughts or things you can take home with you, no matter what your part of the journey you're on, things that will be helpful. And lastly, psychology. We get a bad rap sometimes, and it's because, unfortunately, some of you have been told that it's in your head or something of that nature, and there's hesitancy to see psychology, but I'm going to try to change a little bit of that, and hopefully we'll see some of the ways we can work together in part of your care. So first off, I don't have to go too far into this. We've already heard, but we're looking at the autonomic nervous system. And this is why the condition can be so complex if we're thinking about dysautonomias, is that there's so many areas of the body that are impacted. And oftentimes these different symptoms that seemingly could be unrelated occur. And it's because throughout the entire body we're affected. And the other problem that comes with this is we have so many different areas of our body that are being challenged that we don't always know where the provider to go to, who is our home base. And it becomes more difficult. So with dysautonomia, if I'm just going to give a very brief look at it, we have the dizziness, the tachycardia, the fast heartbeat, the fatigue, and all these other difficulties. But then we have tons of doctors. We have a visit here, a visit there, and weeks that can be just filled with appointments. And then the impact on life too. And this is definitely not exhaustive list of all the ways that life can be impacted. Now, to continue with the physical aspect of it, etiology is just our fancy way to say what caused this. Now, technically, it's very individual, and we don't always know what causes it. I wish we did. We do know that there's this failure of communication between the autonomic nervous system and the rest of the body, which is helpful. But how we get there or why we get there, it can be a host of reasons. Now, some of these, there's genetic components. The autoimmune components were mentioned earlier, and those can play a role. But the way we often see it is some type of, we call it an insult to the body, an infection, a trauma, whether physical or emotional, other things like that. And health behaviors have a role, but as noted previously, you can have somebody that's very healthy, but still get dysautonomia. And if we're looking at some of the newer research, I didn't put it all on here, there's other things that play a part too. So there's portions of the brain, if we're thinking neurotransmitters such as norepinephrine, that stimulate the sympathetic nervous system. They're more active within dysautonomia. There's more release of certain types of proteins called cytokines, which can cause inflammation in the body, also more common within dysautonomia. And even more interestingly to me, because I also do pain psychology, that's one of my favorite areas, is that the central nervous system, there's some new research that's showing that there's central nervous system involvement in dysautonomias. I find that interesting because oftentimes in chronic pain, there's this wind up of the body in the central nervous system. We call it central sensitization, which leads to these hypersensitive nerves, which are often seen in our pain syndromes, amplified musculoskeletal pain, fibromyalgia, things like that. And I don't really find it a coincidence that so many people with dysautonomias also have comorbid pain. So a lot of physical things that are happening within the body, which we have to note. Now, the non-pharmacological recommendations have already been gone over. Good job, Dr. Gold. But I do want to mention these because it's where we start, and they all play an important role. We have the exercise, the cardiovascular conditioning, the strengthening, especially the lower body, really just things that help the blood move throughout the body, get it to the heart, get it from the heart, and moving nice and efficiently. Hydration, salt, I don't have to tell you that one. Y'all probably know that pretty well by now. Counter maneuvers, it was mentioned briefly, but these are just things that, again, help the blood move through the body, whether we're talking about squeezing and releasing, especially in the lower body before we're standing up, which can help blood move around. I heard about the pulling one just a few weeks ago. I didn't even know about that, but apparently that can help out with if you're starting to get symptoms of fainting. And there's other ones too. That's not the scope of this talk. But mental wellness is a piece of this. And it's a piece of this because, as you heard and is correct, whenever we're having problems, whether it be before or after dysautonomia, they do impact the body. There was this thought a long time ago that it's dichotomous, that you have your brain and your emotions, but that's simply not the case. In fact, we know that depending on what our thoughts are, depending on what our emotions are, it has a very real physical impact on our body. So mental wellness is part of this non-pharmacological recommendations that we typically give. Again, unfortunately, some of you have been told this in the incorrect ways. All right, now let's really get to it. Whenever we look at the research, and there's not a lot of this out there, there's probably a good 30 studies that I'm aware of at the moment, we find that compared to healthy populations, if we're looking at those with dysautonomia, there's an increased rate of anxiety, there's a decreased rate of depression. I mentioned pain because it's pretty common too. Pain catastrophizing. Catastrophizing really just means that I have these symptoms and they're scary and they affect me in a lot of different ways in my life, and we worry about them a lot. We know that there's more symptoms, especially orthostatic intolerance. That's that difficulty standing, difficulty walking and moving. The more symptoms we have, the worse our mood gets. We find that in a lot of different conditions. This shouldn't be too surprising. If we're not able to do some of those things we want to do, it affects us, and depression's been the big one for that. Now, these last two, these were a couple attempts at establishing a base rate for what are mental health concerns within dysautonomia and how often they occur. The letter N just means the size of the sample. So these are both really small studies. If we're looking at base rates, they're way too small to really establish anything. But one study said, hey, looking at the general public and looking at dysautonomia, we got about the same rates of mood disorders. Whereas another one more specific to POTS said, no, not at all. Those with POTS have this enormous amount of mental health concerns, especially depression, as compared to the public. Neither of these studies is enough to really tell us what's going on. And I know that more research is needed in this area. But the findings from them, one was to say that, hey, this isn't a mental health condition. The other one is to say, hey, there's a lot of problems going on. They're both correct. What we do know is that it affects mental health, and I don't think this is something that is explained well. And I'm going to get into the reasons why it affects you. Quality of life, it's one of my favorite constructs I like to work with. And what this is looking at is how well you're doing in different domains of your life. So this is a model, one that I like to use, and there are other domains of life, but these are the big ones that get affected. And we know there's about, again, 30 studies that look at quality of life and dysautonomias in general, about 11 of them that look at POTS. We know in this that if you have either these dysautonomia or POTS, there's going to be a level of impaired quality of life. And so that means that life isn't going to be as functional in some of the areas I want to be, that I'm not able to go to school as much as I want. I'm not able to attain that job. I'm not able to do stuff with friends. Also, we find that if you have more symptoms, it's affecting you more. Quality of life is worse. And especially in the total score, when we put all these together, or the physical areas, those are the two that really stand out. Now, I have to say a little bit more about the physical area. Again, mental health is part of this, but how much should be a question. If we're looking at some of the studies, a lot of what changes with quality of life, why we see this change, is when life changes. You have someone that's able to do a lot of things. I'm able to go to school. I'm able to go to work. I'm able to play this sport, to see my friends. And then the physical functioning changes to a level where now I can't do those things I once did. And that's where we find this huge change in quality of life. In fact, that is more impactful, they've had a study that looked at this, than mental health. So to say this a little bit more clearly, the impact or the change that happens in life impacts quality of life more than mental health does. Very important. Now, again, mental health is important too. I have a talk about it. But we have to know that. And that's part of why the priorities for when we're treating dysautonomia is to work on physical functioning. How do we get you a little bit closer to doing those things you want to do and getting back to those places you were? All right, a poll. Now, if you have a phone, this is pretty easy. You can just scan this QR code, much like you would at a restaurant, and no sign up needed. All you got to do is click one of these. Hopefully, it'll give us some answers. I haven't used this before, so we're really going to hope on this. All right. It says active poll. I don't know. All right. There we go. Somebody got it to work. Well, as this is coming up, unfortunately, I already know what the answers are going to be. I imagine you do too. There's a lot of providers out there, a lot of providers that have been trained very well in their schools. They've had years of training. They know a lot about many medical conditions, but they may not know about dysautonomia. In fact, we have very well-meaning providers that help kids, that want to help kids, or adults too. Sorry, I work with kids. That's my default. But they don't always explain things the way we want them to. In fact, sometimes they get stuff wrong. And when we have a lack of understanding, when we have a lack of education in a certain area, that's when mistakes are made. And I haven't looked at the results yet, but I guess they're behind me that show that. Yes. I'm glad somebody had this experience. But as you can see on here, and it's pretty much consistent with the talks I've had with different people, the patients I've seen, or even the research that we have in the literature, generally, you have those top couple. You have providers that say this is in your head. You have providers that say you're anxious, that's the problem. And if we get rid of that anxiety, your dysautonomia will go away. That's not how this works. And on behalf of them, I want to apologize to you because that's incorrect. And not only is it incorrect, scientifically it's incorrect, but it's invalidating too. Because you have this real experience with real symptoms. Now, notably, you can have both. You can have anxiety and dysautonomia. In fact, many people do. And you can have anxiety before dysautonomia, but it doesn't mean that that's the cause of it. And if you have symptoms and it feels like your body's been taken over and things aren't working the way you want, you might be a little bit anxious about it. And that makes sense too, and that's okay. Now, for you that have had those tough ones, especially when they've literally said it's in your head, my hope is some of that changes. I'm going to talk about that in a minute. And I also hope that you found some providers, they are out there, that can be a little bit more understanding. All right, this Tava mentioned my paper earlier. I really like this paper, but I really hate the results. The study is a qualitative study. It's supposed to be a small sample study where we interview people. We interviewed both patients and their caregivers in this study. And you get all their responses and you transcribe them. It was a couple hundred pages of single-spaced dialogue, fun to go over. But through that, you look up you look for the different themes that come up with what they're talking about. We have 4 themes here, and they probably make sense, probably hit home for some of you. First one, already mentioned it, but quality of life. It gets wrecked with this condition. And this was about POTS, but I imagine it applies to any dysautonomia. The second one is this feeling of invalidation. In fact, having an invisible illness was the phrase that came up over and over again. But it wasn't just providers, though. And doctors, we talked about that in a slide ago. We often give them the bad rap of being the ones that invalidate us, but it's friends, it's family members that don't understand. It's people at our school and the teachers or the administration. There's lots of different ways that people get invalidated. And as was said earlier, you can have somebody who looks healthy, who otherwise seems healthy, but there's a lot going on inside their body that can't be seen. With this, we found that there's a need for trust. And this trust concept was both in trust in your own body. If you're somebody with dysautonomia, you know your body pretty well. And to believe yourself. It's unfortunate. There's a lot of people that say, I think I'm going crazy. There's these things happening to me and I don't know why, but you do know your body. And for the parents in this one, and I would say for anybody that's an advocate, a friend, a family member, the trust in that person you love that has dysautonomia, to believe them and to support them. And then also to advocate, and we're going to talk about advocacy in a minute as well. And lastly, this is a novel condition with not enough resources. There are resources, and we know that, but it's still something we have to build up. And when we compare it to other conditions that are out there, this is one that's still pretty understudied. Now with this, like I said, we collected quotes, and there's a couple quotes that I'm going to share with you. I'm going to read to you here in a second, just because to me, I think they really capture part of what it's like to be a family with somebody who has dysautonomia or POTS. So this is from a parent. The GI specialist said, "Think healthy thoughts and you'll be healthy." What does that say to a type A kid who's good at everything they do? You're not thinking healthy thoughts, and that's why you're sick. And so this is all in your head, basically. And we get in the car after one of those doctor's appointments. And the specialist, and she just break down in hysterics and just be crying and sobbing and saying, "What's wrong with me? Why do they keep telling me nothing's wrong with me? I hate this. You should too, and I know that some of you have felt this." It's this unfortunate thing that happens over and over again. Now, I put this up here because it makes sense that we have mood conditions that are associated with this. It makes sense that people are struggling. There's all these things, not only that are happening inside our body, that are happening around us. Now, what do we do about this? First, as was said earlier, education is the biggest thing we can do. Educating ourselves, educating the people around us. And I think the involvement helps as well. And we have all these people listed up here that are involved today. There's also many other wonderful organizations that help with dysautonomia. But involvement in them, learning more, and even pointing our providers towards this, or the people that don't understand. Those providers, those ones that said, "It's in your head, this is fake, this is anxiety," they can change. Many of them do. But sometimes they just don't have the information and the knowledge to be able to do that. Along with this, the research, there's not enough in it. And there's all kinds of studies out there, some that involve treatment and medication. Mine are usually more surveys and interviews. But there's plenty more we need to know and understand. Along with this was mentioned earlier, to build your network, whether it's through groups like TDP, or maybe it's just knowing other patients, knowing other families, or just having a strong core group of friends or somebody that can support you. And of course, advocating. And this is advocating for when you're working with doctors, it's advocating when you're working with schools, it's advocating with your friends or family, and again, supporting both yourself and those people you care about that have dysautonomia. Now, functioning is big. It's one of the bigger things we're going to push on this, and especially if we're thinking mental wellness, it's something that we have to have happening. It's 2023. We've known about dysautonomia for a little bit, but the treatments aren't perfect yet. We don't have a quick answer. And in fact, in some cases, it's very patient-led, in which you're going to have to do a lot of things, and it's tedious and it's difficult and there's challenges. And so what we want to do is take this slowly, just do a little bit more. And when we're thinking about doing a little bit more, it might be school, it might be trying to work some, it might just be getting out of bed or trying to move a little bit more. It doesn't really matter. It can be very individualized, but something that means something to you. It takes accountability as well. Usually we need somebody to have our back on this. Typically that's the form of a family member, a parent, or someone like that. But this is tough. What we're asking is providers for patients to do is a list of things that take time, that take energy, and we don't always have those. And lastly, even if things aren't going the way we want, we're not able to do all those things that we're hoping for, to start to build some structure in your day. Now, you're all here, my friends that are online. I imagine there's somebody watching who isn't able to leave their bed or able to do some things that they'd like to do in their day. People have different parts on their journey where they're at right now with dysautonomia. But even being able to create some sort of structure, some sort of semblance of what I want life to look like, and slowly working towards there can be helpful. The mental health, again, is big, and this lists a few things we can look out for, and there's mood change and the management of it. We know that there's all these impairments that happen, or maybe it's bigger things where we start noticing people change a little bit or lose interest. whatever it may be, considering mental health is going to be helpful. Now, this last one, the self-harm. Self-harm and suicidality are something that do occur in chronic illness. And Tavis' story is not the only one I've heard where we've had this type of thing happen. And I do want to note that if we are talking about this, we have to know that this is a condition where maybe not life-threatening, but it's not benign. There's a lot of mental health problems that can come from it, and there's a lot of behaviors that, of course, we don't want. So if you're looking for these are some of the things, if you hear your loved one talking about, or even some of these behavior changes, I have these up here, but when I think of them, saying that the symptoms are unbearable, or I don't want to deal with it anymore, I don't want to wake up, isn't very uncommon. We have to individualize this as well. And isolation, if you know many teens, isn't exactly something that's abnormal, but maybe it's the change that you see. Now, if needed, of course, 911's your go-to, but there's different resources that you can tap into. I do have to note something, though, because many of you have been infected by suicide, whether in this domain or some other, but there's no way to predict it. And that's coming from, I have some people I worked with who are experts in this field, who do the research on suicidality. And there's no way that we can know who's going to do it and when they're going to do it. And that's something to consider when we're looking back at things that have happened, or we're considering what happens in the future. What we can do, though, is the check-ins. And for parents, I'd encourage you, if you're seeing some of these things, check in. For friends, check in with them. And for my teens that are here or watching, if your parent starts asking, I'm sorry, but it's part of the gig. We want to keep you safe. All right. So let me move over to psychology. I told you I wanted to repair our relationship, dysautonomia and psychology, because I think psychology is one of the areas that can be helpful for management. First is this adjustment. Like we said, there's so many changes that can happen to life. We need to have somebody to help walk us through that. Now, these are just a few of the things that can be part of that adjustment period. But the fear, the learning to have self-esteem, especially if I'm not ambulating the way I want to do, what are people going to think of me? We mentioned grief, but I've heard people say that without anyone dying, that I feel like I'm grieving. I'm grieving this past part of me, but it's gone now. And I remember specifically a young lady mentioned to me, I feel crazy because nobody died. Nothing changed except my life. But like I told her, and like I'm going to tell you, nothing crazy about that. And with grief and with that loss, it's something we can expect, but it's also something that is part of this adjustment, part of this process, and it's something I hope that psychology can help with. Doesn't mean anything's wrong with you. It just means that we're dealing with a really unpredictable and difficult condition. But there's other ways we can help. So up here, I mentioned a couple of the therapies. Cognitive behavioral therapy, CBT, which is this trying to change thoughts. If you have unhelpful thoughts, trying to make them more helpful, especially in a way that promotes your emotion to be more helpful to you, or your behaviors. You're able to do the things you want to do. And then ACT, which is acceptance and commitment-based therapy. And this therapy is more based on acknowledging that things may not be okay in my life, but that's all right. I can still work towards the things that I value. Now, I mentioned these two. There's plenty of therapies out there because these are the only two I've seen any studies on where they've worked with dysautonomia. And even those are very small studies, and I can only think of 2 or 3 off the top of my head. All of this, and I'm not going to go through all the words, you can see it. All this is mentioned because even without dysautonomia, people have problems. And my guess, if we looked at the room right here, if I knew everybody online, there's probably a good portion of you that have anxiety, that have depression, that have these other difficulties in life. And I would recommend for most everybody in here, I'm going to say about 100% of you, you might need psychology at some time in your life, and that's okay. We all do. But this is something that can be especially helpful if, again, we're struggling and we're having difficulties, whether the anxiety or depression is before or after the condition. Now, again, it does impact it. It's not the cause, but it impacts it. We said it earlier. If you're anxious, it's going to impact your sympathetic nervous system. It's going to dysregulate your autonomic nervous system. It doesn't help. And if we're feeling depressed, it's harder to do those things we know that do help. It's good to get help with these. Assisting with functioning. We're going to hear, I think, in our next talk a little bit more about pacing and building up your life, but psychology can help with this too. And usually it's not so much prescriptive as saying you need to do this and this and this, but this is your advocate. This is somebody that's saying, hey, your accountability partner. Somebody that says, hey, we got to keep on doing this. How do we create structure? How do we overcome the barriers and challenges that are inherent to trying to do something difficult? And along with that, for younger kids, even helping parents or families set behavior plans or to help do reinforcement charts or things like that so that we can reward some of these extra efforts that teens have to go through. And the other part, this one I really like, and I don't think the people online got to see the stretching demo. If you didn't, you missed out, but a lot of you got to see it. There's a lot of self-regulation skills that are helpful, and they're helpful because of how they impact the autonomic nervous system. Now, I'm going to briefly mention them, but we have mindfulness, and you may associate it with meditation, but this calming, non-judgmental way to think about the present and what's happening right now, which is nice. There's lots of studies that show that it helps the heart, it helps the body, that whole autonomic nervous system. We have paced diaphragmatic breathing. So this was already explained to a lot of people in the audience, but breathing with your diaphragm is really helpful. It's your diaphragm down here because it's connected to this thing called your vagus nerve, which is attached to all the major organs that your parasympathetic, your calming system is attached to. And so by activating the vagus nerve through diaphragmatic breathing, it calms the body. And this is something you probably know. I think everybody, at some point, you've had somebody say, hey, take a deep breath. What I hear a lot, though, when I'm working with teens especially is it doesn't work. Now, physiologically, we do know that it does work. We could even activate the parasympathetic, we can activate the vagus nerve's response in a cadaver, in a dead body. So we know it works. The problem is it takes time. Usually 60 to 120 seconds is what it can take to really get that. That's a lot of breathing. Other thing is that we usually use it in crisis. The example I like to give is imagine pushing the brakes when you're going 80 miles per hour on the interstate. It's not going to stop your car. It doesn't mean the brakes aren't working there. However, if you try to use the brakes when you're in the parking lot and you're only going 5 miles per hour, you might see a lot of results. The car basically stops. And I think of that when I think about this paced breathing, is that it's a skill that's used proactively rather than reactively to get those good results. Other thing is the pace part, especially of dysautonomia. Whatever you're breathing in, breathe out. That's going to help out with the autonomic nervous system. And if you are going to do pausing, and so I breathe in 4, I pause for 4, and then on the outside, I breathe out 4, I pause for 4. Everything nice and paced does better for the system. Progressive muscle relaxation, and that's similar to the counter maneuvers you heard earlier, but you can do it throughout your whole body progressively, squeezing and relaxing the different muscles. And what this does is it allows for the body to relax, the muscles to become a little bit more fatigued and relaxed. But for dysautonomia, it has the benefit of also helping blood travel through the body, which can be good, especially before you stand up, can help out with that as well. And then lastly, biofeedback, which probably a lot of you aren't familiar with, but it's just a type of therapy where we use a screen, usually a computer screen. It hooks up to you via a sensor, just a nice little painless one that looks at your heart rate, your blood pressure, your breathing, your muscle tension, things like that. And then the screen shows you what's happening inside your body. You use skills to try to change that, and you gain awareness and control over the autonomic nervous system. So that involuntary system becomes more voluntary. We can control it. So these are all some things that can help, but also things that psychology typically does. There are some tough things I mentioned earlier, but this slide I like. There's hope. Each one of you, your experience is different. Even some of you that might look the same or have the same type of symptoms, what you experience is different. And now that can be tough. It can make it feel like you're alone on an island. But I think it's good too, because there's a lot of different ways we can get about treating this. Now, dysautonomia, or any of the forms of dysautonomia, they're novel. They're not well known. We don't have they're pretty well known, but we don't have enough research on it, not compared to other conditions. And because of that, the science is a little bit behind right now. Now, that stinks in the short term because a lot of you are still struggling. That's probably why you're on here. But it also means there's hope that the science is going to catch up, that we're going to get more medications that are able to treat what you're experiencing. We're going to get more tailored interventions or more access to them. So we're going to have things that help. And part of it is hanging in there a little bit longer and knowing that things will continue to improve. The goal, though, isn't perfection. And I do want to mention that because a lot of what we're talking about today is to be able to do more, to live more life. The goal is to change things for yourself, things that help you live the life you want to live. I think that all of us have the things that are important to us. Some of them that have been changed because of dysautonomia, some of them that we're just no longer able to do. But there's still areas of life that are important to us. If we can slowly work towards those, inch by inch, day by day, it might not be something huge. It might not feel like it's enough. But I think that's where the goal is. And I believe that there's hope that we can get closer and closer and closer to those things that are most important. So, what do I want you to take away from this? It's not a mental health condition. I want you to know that. I want you to believe it when you go into an office or you're talking to a friend or talking to a school teacher or anybody that just isn't understanding. Please note, I'm a psychologist. I can say this with authority. This is not a mental health condition. But it is difficult. It's challenging in so many ways. And because of that, you're going to need help. Get help from your friends, get help from your family, get help from psychologists, or even what you're doing today. Getting this education, being able to be part of something, to meet people, to learn different strategies, those are the things that are going to help us. And it's okay to seek that out. We don't have to have the whole world on our shoulders. But finding those resources to function. This is going to look different for everybody, what the resources are, or even what functioning means to you. But it's something we can do, and there's resources out there. There's more resources coming. So, for all of you, I hope that you know that this journey is a long and hard one, but know that there's things you can do and there's people that can help. So, thank you.
That was a great presentation. Putting together the videos that we've done for dysautonomia and this whole notion that you think you're crazy. I mean, that is the people that I have known that now are working on dysautonomia, that was the first thing that triggered me to them, was this whole notion that you're nuts. Yeah. But it's one thing, you're a doctor and you're talking about these other doctors, but the reality of it is, let's just talk about the reality. Your insurance company tells you which doctor to go to. And then if you're going to go to the second one, then you got to get a referral. And by that time, you've dealt with 2 or 3 other doctors and you're getting so many opinions, even from those doctors, before you're even starting to get diagnosed. How do you prevent your mind from going to that part? A million people can tell you you're not crazy, but that little voice in the back of your head says, I'm nuts.
Yeah. Here's the unfortunate part of it. I don't know if we get rid of that voice that's inside. If we look at the research, and there's some papers, some of these are a little old now, but most people are going to see several providers before they're diagnosed. And during that time, it's hard not to get down on yourself. It's hard not to imagine that, okay, it must be something with me or my brain or something not working out that's mental in nature. I don't think that's what we are able to necessarily change. It's part of the process for most people. I think it's more of how we respond to it. I think it's, again, coming to a day like this and knowing more about mental health and how it relates, but also as you then go and get to your providers that are able to validate it, to explain it to you in whatever way makes sense, as well as seeing mental health and knowing that it's not the whole piece.
Yep, that's good. Okay, question over here.
Are you aware of any studies involving EMDR or art and dysautonomia? I am not. Yeah, great question. I know a couple of people actually that do EMDR and have dysautonomia, and for both of them, it's more related to trauma type stuff. There just isn't research. And when I say there's not research on it, the 3 studies I can think of that look at therapy were from Mayo Clinic and their is chronic pain in their POTS program, where in part of the multidisciplinary program, they do ACT or CBT. there's not a study right now that I'm aware of, and I'm very much in this research, that says if you do this therapy, it's going to help. So we are basically at ground zero when it comes to what is the mental health therapy most helpful.
Okay, this is a really good question. What would you recommend for a patient who is struggling with denial regarding their diagnosis?
I think it might matter of what they're denying. I think if they're denying the fact that they have symptoms, that might be a little bit easier. I think it's more of the, okay, I have symptoms, but this is normal. Is the person that asked this in here? Can I point you out? Okay. Do you mind if I ask, when you're thinking of the denial, is there a certain aspect of it that they're denying?
She's talking about when she has for all those that are, she's talking about when you're trying to push through it and you're having a really, really hard day.
I think if somebody is in denial in that regard, so there's somebody who, okay, there's stuff happening, but I'm going to push through. I'm going to push through. This doesn't affect me. I can overcome it. I can, tough it out, really. I think most people over time realize that isn't always the case, that this isn't a syndrome where if you're strong and mentally you're there, that it just gets better and goes away. In fact, it's one that's very stubborn. And so for the people that are pushing through it, or sometimes not able to, I think that if I was working with them, it would be more of trying to find out, well, how do we have acceptance of this? And knowing that there are some modifications going to make, as well as working with them to say, okay, you're pushing through it for a reason. There's something you're going after. There's parts of life that are really important. How do we still go after those parts of life that are important without really just pushing or trying to push through everything, which of course can then cause us to be laid out for a couple of days. So it'd be both accepting, but still trying to see how do we modify and continue having those values.
So how do you find a doctor to treat this? What do I look for, particularly in knowing whether you should ask for somebody who's going to treat you with any kind of a therapy or?
Yeah. I think word of mouth is typically how I hear it. People say, oh yeah, I see this person. And if you have a support network of other people with dysautonomia, you can say, hey, who do you see? On the website, do y'all have a list of providers? Yes, go to the ABPP website. There's a whole nice list of them. That's where you want to go. Unfortunately, it doesn't always work like that. We mentioned insurance earlier. Sometimes you're forced to go to certain providers and you may end up with providers that don't understand. I wish that wasn't the case. It is. I think in those cases, though, because we don't always know what the provider is going to be like, to be able to advocate then, to be able to bring some of that education and help them understand. Again, I think most doctors are good people, if not all of them. I think most of them are trying to be good people. And the fact is, a lot of them just don't understand dysautonomia, or in their training, they were told things that are incorrect. And I think the more they understand us, the better they'll be.
And give them the book. Boy, you got that.
Yeah, give them the book.
Yeah, yeah.
Please do.
Do you have any more questions right there in your hands? Or we're going to grab one more here. Okay.
And I'll be around afterwards too. I know we got to wrap this up, so this will be the last one. How do you find a good mental health professional that understands dysautonomia? It's hard to get all in a bunch. Just because dysautonomia isn't something mental health providers are trained in typically. I'm a pediatric psychologist, so that was really the route I went. I think what you got to aim for, though, maybe isn't somebody that totally understands the ins and outs of it. Somebody you trust, somebody that believes you, somebody you connect with. If you can get that, you can allow them to know more about dysautonomia, but you got to find that person that's going to be in your corner. That's the big thing.
And let me ask another question. So, because we mentioned suicide, does a person that have dysautonomia, and this may be a stupid question, but I'm asking it anyway. Does a person that has dysautonomia or another disease which they may believe is fatal, do they consider suicide differently than someone who does not have a disease or a prognosis that says that they might die?
I don't know if there's research out there to really answer the question about this group thinks about it differently. What I can say is with chronic illness, especially one where you feel like your body has been overtaken, I think for a lot of people struggling with the symptoms, why is this happening? And especially in the context of having people invalidate your experience is going to increase the likelihood to give up on it. So I don't think it's anything about the condition specific.
Okay. And I think that's going to wrap us up right now. Doctor, thank you so much. And thank you for your talk to us.